So this week we're just going to be doing a short, quick neonatal case on one of the neonates that challenged a bit some of my junior doctors in the NICU this week, mainly the blood gas of the patient. So on looking at the history, this was actually a 2-week-old neonate referred from a district hospital with recurrent seizures and an elevated CRP of 215. After having seen and examined the patient, we made an assessment of late neonatal sepsis in septic shock, and the patient was also in status epilepticus, which we thought it's possible secondary to a meningitis in light of the severely high CRP. The patient was also found to have a severe pneumonia with a lower airway obstruction because the patient was wheezing quite a bit on chest examination. So this is a patient who actually needed to be ventilated, started on mid-dose infusion, and covered with antibiotics and covering for possible meningitis. Now, this was the guess done after doing the septic workup of this patient. This was the initial guess that was done from this patient. pH was 7.21, PCO2 was 6.5 in kilopascals, PO2 was 10.2, bicarb was 15, and the base excess was minus 14 with a lactate of 3. So after having seen this guess, we made an assessment of a mixed acidosis, and this is where some of my junior doctors got challenged by this case. So please stay with me as I try to explain to you how this might have come about in this patient. So we're just mainly going to be talking about this mixed acidemia in this neonate. Welcome to Pete's Crib, where we guide young minds to heal young lives through case-based discussions. I am Dr. Manyesane, a pediatrician based in East London. If you find value in our content, don't forget to subscribe, like, and share with peers. And make sure you hit the bell notification so you never miss an update. Let's dive in and grow together. Okay, so let's start by interpreting the guess. So the first step that you would want to make sure you do is to identify your pH. So this patient's pH is 7.21, which means acidosis, because a normal pH is 7.35 to 7.45. So that's the first thing you do. You discover that the patient is acidotic. Then you look at your CO2, trying to find out, is this a respiratory or metabolic acidosis? The patient has got a CO2 of 6.5, and normal CO2 is 3.5 to 5.5 kilopascals, or 35 millimeters of mercury to 45 millimeters of mercury. Then on looking at this patient's CO2, which is above 5.5 kilopascals, then you can safely say the patient is retaining CO2, and therefore that acidosis is caused by respiratory problems. So it is a respiratory acidosis. Okay, then the next question you ask yourself is, how is this patient normally supposed to compensate to this respiratory acidosis? So patients with respiratory acidosis, they compensate by metabolic alkalosis. So they have to retain bicarbonate from the kidneys to compensate for the respiratory acidosis. Why do they have to retain bicarbonate? So if we think about it, when CO2 is mixed with blood in the circulation, they form what is called carbonic acid. So that's what actually drops the pH when a patient is retaining CO2, is the formation of that carbonic acid. Now, the reason why the body or the renals or the kidneys have to retain bicarb, they are trying to buffer that acidity. They're trying to buffer that carbonic acid so that the pH increases, or they try to normalize the pH by buffering that acidosis by retaining bicarbonate. Then you go and look at your bicarbonate. Now, on this patient, instead of retaining bicarbonate, the patient was actually having a low bicarb, which is something that you were not expecting, because you were expecting this patient to be having elevated bicarbs. And normal bicarb in pediatrics is anything less than 22, we say it's acidotic, unless you are a premature baby, because they are allowed to have slightly low bicarbonate up to the 18s because of the immature renal tubules. But a normal neonate, a term neonate or pediatric patient, a bicarb of less than 22 is a low bicarb, and therefore the patient has got a metabolic acidosis. So this patient, who is supposed to be having a bicarb on the higher side because it's supposed to be compensating for the respiratory acidosis, instead is having a low bicarb of 15, which is less than 22. Then you safely say this patient actually has a mixed acidosis, is having a respiratory acidosis and a metabolic acidosis. And we also look at the base excess. A base excess of more than -4, it's significant. It also points to metabolic acidosis. And our patient's base excess is -14. Okay, and the patient also had a high lactate, which points to the metabolic acidosis, because remember we discussed this, when patients are in shock or poorly perfused, they will go into the anaerobic respiration and therefore release lactate. So from interpreting this guess, we can safely say we really have a mixed acidosis because we have a respiratory and a metabolic acidosis. And if this was a primary metabolic acidosis, so let's say the patient didn't have this mixed acidosis, so how do we expect a patient with just metabolic acidosis to compensate? Because we have explained the compensation of a respiratory acidosis. So if this was a plain metabolic acidosis, which we would expect in this patient because the patient is septic and in septic shock, so the patient was going to compensate by blowing out CO2 by hyperventilation. So metabolic acidosis, the compensation to metabolic acidosis is respiratory alkalosis. So the patient has to hyperventilate. They will have that acidotic breathing, which blows out the CO2. And the reason why they have to blow out the CO2 is the same explanation, because you don't want CO2 to be high in the circulation when you already have a metabolic acidosis, because a high CO2 will mix with water and form carbonic acid and worsen your acidosis. So that's why metabolic acidosis compensates by respiratory alkalosis. But now in this patient, again, you are not finding that. Even though the patient is having metabolic acidosis, but is retaining CO2, instead of blowing out CO2, is not blowing out CO2, instead he's retaining it. So the question you need to ask yourself, why is the patient not responding the way that you're expecting them to? If this was a primary respiratory acidosis, why is the patient not retaining bicarb? And if this was a primary metabolic acidosis, why is the patient not blowing out CO2? So to answer your question of why is this patient not compensating the way that we would want him to, we'll actually need us to go through this patient as what we were expecting to see in the blood gas of this patient and why we are getting what we are getting. Firstly, we have a septic neonate. Very elevated CRPs of 215, and then when the patient was examined, was found to be in septic shock. So in such a patient, when you're doing that blood gas, you are expecting to see metabolic acidosis, because if they are in shock, it means there's decreased perfusion to the tissues, and if there's decreased perfusion to the tissues go into an anaerobic respiration with the release of lactate and therefore metabolic acidosis. Okay, so we were expecting metabolic acidosis. Then why is the patient, if we had said the response to metabolic acidosis is going to be hyperventilation, meaning that the patient is supposed to be blowing out CO2, so why is this patient not compensating and blowing out the CO2 that he's supposed to? So this can be explained by two things in this patient. This patient has got a respiratory problem, a severe pneumonia on the x-ray, which could also explain the severely elevated CRP. And also the patient has got a central problem, which is status epilepticus. The patient might be having a meningitis. The patient might also be having cerebral edema from this status epilepticus. So you have two organs that are responsible for this, because respiratory-wise, if that severe pneumonia has distracted most of the alveoli, it means your gaseous exchange is going to be affected, and therefore the patient is not going to be able to exhale CO2. And with the CNS problem, if you have anything that causes CNS depression in this patient, and in this case it will be the recurrent seizures that the patient was having, possible meningitis that this patient might be having, or cerebral edema that this patient might be having. So a central hypoventilation will also lead to the high CO2. So that would safely explain why this patient is retaining CO2 instead of blowing out CO2. So I hope that makes sense. And this concludes our video. So it means next time you have a patient with an acidosis and the patient is not responding, especially metabolic acidosis, and the patient is not responding by blowing out CO2, it means you must think about these two organs, that there might be a respiratory problem going on, which makes this patient retain CO2, and there might be a CNS depression, which makes this patient hypoventilate and therefore not excreting CO2. I hope that helps. Thank you.